I'm Alicia.
And I'm Liam. We both have OCD. And instead of spiraling alone, we decided to turn our symptoms into a podcast. You're welcome.
Here, we overshare real stories, laugh through the anxiety, and talk to actual experts who can explain why your brain keeps asking, what if I accidentally marry my cousin?
Whether your thing is hand washing, mental rituals, or just silently panicking during normal conversations, congrats. You have found your people.
This is a safe place. Unless you're an intrusive thought, in which case, get in line, buddy. We're booked.
So grab a weighted blanket, cancel your plans for the 5th time, and let's dive in. This is the OCD Confessional.
And yes, we did check this recording 4 times before uploading it.
Today on the OCD Confessional, we are joined by 2 leaders from the International OCD Foundation who are helping sound the alarm on a crisis in mental health care. Becky Deusser and Dr. Sanjaya Saxena are here to talk about the IOCDF's newly released white paper, America's OCD Care Crisis, the largest ever study of people with OCD, and it reveals just how limited access to evidence-based OCD treatment is and what that means for individuals, families, and the healthcare system as a whole. This conversation is about the data, but more important, it's about the people behind the data and what needs to change so that those living with OCD can actually get the care they deserve. So Dr. Saxena and Executive Director Becky Deusser, thank you so much for joining us. We really appreciate it.
Welcome.
Thanks, Liam. Thanks, Alicia.
Yeah, thanks so much for having us.
We want to go through some of the headlines from the study because there were so many that stood out to us how dire this situation is. So, Becky, if I could start with you, just how underdiagnosed this disorder is, what you found in this study on that.
Sure. So I can start with the highlights and Sanj or Dr. Saxena, please do jump in. So the highlights as the upshot is that up to 10 million Americans have OCD. It's up to 3% of the population. And of that group, only a small fraction of them are getting documented diagnosis of OCD. So that's just 1 in 6.
Wow.
With that level, it's really such a small number. And of that group, of that very small group of people who get a diagnosis, the number of people who are getting the gold standard recommended effective treatment, which is ERP, and we'll talk a lot about ERP as you do on your show already, a very tiny fraction, about 2% of those individuals are documented having ERP in the study that we performed. So that translates into 95% of those Americans likely to have OCD are not getting effective treatment. It's a staggering number.
That really is alarming. And what do you think are the biggest barriers that are preventing people from getting the proper treatment?
There are a number of barriers, and the study, in fact, bears that out. Why the IOCDF exists is to address some of those factors. So one is awareness, and what we like to say is correct awareness about OCD. So for clinicians and the general public alike, there's a very low correct understanding about what OCD is. It is a serious mental health disorder that can be debilitating for many millions of people throughout the world. The lack of awareness and stigma of having OCD, and with you two who have lived experience with OCD know all too well, many people themselves don't even know that they have OCD because there's that lack of awareness, and they may be having like those, I've heard Liam share his story and you as well, Alicia, and listening to the podcast, a very, I would say, not as a non-clinician, very clear, like textbook symptoms and signs of having OCD that was not diagnosed for a very long time. And you yourselves not understanding that was what was going on until you saw a professional who helped you kind of get on that diagnosis path. And that's the same for clinicians. Clinicians don't necessarily understand all the symptoms and signs. And even though there is training available and there is professional standards to help guide that practice, and Sanj can speak more about that, it's generally not happening. People with OCD are getting failed every step of the way. And that needs to change.
And Alicia and I had both been to therapists in the course of our lives who did not diagnose us with OCD and treated us for depression or maybe anxiety. And there were, as you say, clear indications that we were suffering from OCD, but the system and the knowledge of it, even among those who in theory should have that knowledge, just isn't quite there yet. And I want to clarify, are you saying that Kim Kardashian doesn't have OCD because she likes things neat?
That's exactly right. And, Sanj can jump in. I mean, I think there are so many misunderstandings about what OCD is.
And when we think about what are the factors that explain what our results were and what has led us as a nation, as a world, into the current state, there's failures and problems at multiple different levels. And that's why we have recommendations coming out of the white paper that address things at multiple levels. So at the very basic level is low public awareness, low awareness of what the symptoms are, of what the treatments might be. So even among those people who know they have OCD, perhaps they've received a diagnosis of OCD, still a lot of them don't seek treatment because they're not aware and no one tells them of the effective treatments that exist, including ERP and medication treatment, cognitive behavioral therapy. And then there's poor training and lack of awareness on the side of clinicians and a failure of the system to screen people for OCD.
I'll just add two other things. One is that even if someone does get a diagnosis and they are lucky enough to find a therapist who knows how to do ERP or is familiar with treating OCD and qualified to do it, there's just general access to care issues that exist in our healthcare system. But the truth is, even for mental health generally, there are so few mental health clinicians specifically trained to treat OCD anyway, right? And then we think maybe at best 1%, but we don't have research yet to back that up. There's about 660,000 mental health clinicians in the US, and we think a very small fraction of them are trained. The other piece is not a week goes by where I don't hear stories about from a parent they know their child has OCD, they need to get treated with ERP, cannot find a clinician that accepts insurance and is even remotely close to their area. I spoke to a parent who drives 2 hours each way in Florida to get access to care for their kid, to get treated for their OCD. And it's, and it's not clinicians' fault. And I think I worry about this in the study, and I know Sanj can reinforce this. Mental health clinicians want to help people. That's why they entered into this career. And they're not, it's not that they're not trained well, but they're not trained necessarily on OCD specifically at lots of different steps of the way. And the only other thing I wanted to mention is that there hasn't been a lot of very vocal, large, broad-based advocacy about OCD and access to care by the IOCDF or anybody else. And we recently launched a new strategy that has a big component is to really have full-throated advocacy and being a little bit more pushy, a little louder about these very serious barriers that exist that are fixable problems.
And the failures in training and the failures to sort of offer or provide or refer for evidence-based therapy differ a little bit by discipline. So on the medication side, more people with OCD are getting treated. And our study was about 2/3 of the population of OCD whom we identified were getting the correct type of medication. We don't know the dosing. Very often they're underdosed. That's what previous studies have found. The real striking lack of treatment and lack of referral that's created this huge gap is on the therapy side. And for OCD, that's arguably more critical. ERP and cognitive behavioral therapy in general work at least as well as medications do. And really the combination works better than either one by themselves. And yet that's what people aren't getting. Even if they have a mental health assessment, they're still oftentimes not getting referred for the appropriate type of therapy. A lot of times they're getting referred for non-specific talk therapy, supportive therapy, psychodynamic therapies that we already know don't work for OCD. There's no good reason why all mental health clinicians in any discipline, psychiatry, psychology, social work, MFT, counselors, shouldn't be appropriately trained in how to assess, diagnose, and treat a disorder that's this common, right? And we've often talked that if there was another non-psychiatric disorder that was this common and produced this much disability and impairment and distress, it wouldn't be tolerated, right? OCD affects somewhere between 5 and 10% of all people who are seen in any mental health care setting. So can you imagine a cardiologist not knowing how to diagnose or treat patients who comprise 10% of their entire practice? Right? That would never happen. And yet it routinely happens. And there's no screening. right? So we're not expecting everyone to self-diagnose and then go hunt for treatment. They need screening, right? And they need an appropriate clinical evaluation, and that's simply not happening.
What are the consequences when OCD goes undertreated or misdiagnosed or treated incorrectly?
So the consequences that so many folks, millions of people with OCD in the country are experiencing are chronic symptoms, chronic distress, chronic impairment, chronic sometimes disability. OCD is in most people is a chronic disorder, at least in adulthood, that kind of waxes and wanes in severity based on the level of stress. But the most critical factor in controlling the symptoms and stopping that needless suffering is effective treatment. With ERP, or more broadly CBT and medication treatment.
What happens when someone with OCD gets well-intentioned but inappropriate treatment? I mean, we're saying that 95% of people with OCD are getting no treatment or the wrong treatment. So what happens when that's the case, when someone goes to the therapist or goes to a social worker and gets the wrong treatment?
They simply don't get better. And as Becky was pointing out, sometimes those inappropriate treatments can make them worse, right? So there's a lot of other types of therapy that at best are benign and don't do anything, and at worst make people worse. And it creates more and more frustration, more and more distrust of psychotherapy in general.
Yeah, that's what I was going to say. I stopped going to therapy because I was like, it's not working. I don't feel better. No one understands me. Why aren't people understanding this? I don't want to go home and sit with my thoughts. That's all I do all day. Yeah. I mean, we lived that. Yeah. We went our entire adult lives not having a clue what was going on and just feeling like I battled depression. I just thought that's who I was. That was going to be my life forever.
And even in addition to just sort of ongoing suffering that's not getting better and frustration and feeling of pessimism about therapy and treatment in general, there's also just the very practical things of time and money and cost and insurance money or out-of-pocket money frequently that's being wasted.
We'll make sure we link to this white paper if you want to read it and some of the headlines from it in the podcast description, so you can go there if you want to read more. Becky, how can patients and families tell if the person they're going to see is properly trained? I mean, it's such a labyrinth to go through the healthcare system as it is. You find out whether or not you're in network with this provider. You find someone that's near to you. Oh, it turns out they don't take your insurance, or you finally get to someone who is available to you. How can you tell whether or not they're actually going to be able to help with OCD specifically?
It's such an important question, Liam. So happy that you're asking it. This comes up so frequently. So a couple of things about this. I think in general, unfortunately, we have to be advocates for ourselves or our children. I think we're all parents here, right? And you have to ask questions, especially for a situation like this. And that can be uncomfortable, especially if someone with lived experience is coming in. It's already hard enough to seek help. You're fighting the stigma, you're fighting the resistance of treatment, you're fighting the fear to go in and seek help. So it's hard to interview a therapist and push back if you don't think that they're properly trained or qualified to treat you. But some of the questions that people should be asking are you familiar with ERP? Have you been trained to treat OCD? Have you used ERP before? What percentage of your clinical practice includes people with OCD that you're currently treating? We have a list of questions actually as a resource on one of our web pages at IOCDF.org that has more questions like that. We also have a very robust resource directory that, at least within the US, has all kinds of resources that you can filter through, and if they accept insurance, what part of the country that they're in, what their background is, what subspecialties that they might have, that a lot of people find to be useful as they're navigating through the system to at least find someone who's at least affiliated in some way with the IOCDF. That doesn't always mean for sure it's going to be the exact right fit. But I think those are some of the things that people should be asking. And I think the hardest part is if they don't meet that criteria, I think the best thing you can do is to try to move on and try to find someone else. But that can be so disheartening because it's hard to find good therapists. And even the wait lists are enormous. You know, it can take months to even get in to see a therapist for anything.
But I'd really advocate for people, and this question comes up all the time when we want to refer folks, or people ask questions about, hey, how can I find a therapist who knows how to treat OCD? I always refer them to our IOCDF's resource directory, because it has, nearly 4,000 clinicians. And it's really the only sort of compendium of information where you can look up the information that's on each therapist section, or each clinician section, or psychiatrist section, and actually find out some of the answers to these questions, because we ask them to provide that information. So they have to list what training have they received, how long have they been treating OCD, what's their experience, what techniques do they use and know how to use, in addition to practical things about, do they take insurance, do they do home visits, do they do teletherapy, etc.
I wonder what policies would make the fastest impact for families. And do you guys see that happening soon? And what can we do to keep it going?
It's important to say, when I said earlier, these are fixable problems, they are. And other mental health disorders that I won't name because that can be upsetting to people who may have them, have had a lot of success through advocacy to raise awareness about specific disorders and demand for either screening, insurance coverage, treatment requirements that can be done at the federal level or at state levels. So they are fixable problems. However, they can take time and be a long road to implement those changes. We think that at the top of the list, and we've laid out a number of recommendations and things that need to be different, is similar to what Sanj was saying earlier. It is screening, requiring screenings in settings such as pediatrician offices, primary care settings, even among mental health clinicians who are maybe more generalists. That would start to get a better picture of people who are struggling, and at least get them on the path of identifying that they may have OCD and get them referred to a more detailed screening and intake. One of the things that really stood out to Sanj and I in the data, and there's so many statistics in there that are hard to read at first. And I remember specifically us being in this meeting, we both just stopped and we were like, oh my gosh, this is shocking. Is that, of the 72% of people with OCD not getting referred to more treatment, half of them got a documented mental health assessment, and they still didn't get referred to any treatment. That's shocking.
Do clinicians just simply do not know? Is that a
Yes.
graduate school problem of learning where and what to do even after the screening? Why don't we have the proper screening right now?
Right. So yeah, all of those are problems, and I think training and insufficient knowledge of what to do, and then even for those who may know of what to do, insufficient adherence to practice guidelines. So people just sort of following their own ideas about what therapies they like to do, and therefore they'll just do those rather than doing the one that's listed in, page 1 of any textbook on OCD.
Performing ERP as a clinician is hard. It takes very nuanced training and confidence to do it. It does require some degree of your patient suffering a little bit, right? And really pushing through difficult things. And we hear this all the time from some therapists it's hard to watch. It's hard to put them through that. And there's resistance to doing it. And we think that is, and there are studies that back that up, that are cited in our paper. So that's why training is so important, but it's not just training about ERP is the best treatment. It's encouraging clinicians to get trained how to do it and then have that confidence and support through case consultations, mentorship. Some of those things we offer, some of them are offered through other higher ed institutions. That's really where it could start to change and turn the tide. And that's something that's hard to enforce and change by policies unless it's a requirement to get licensed or something to that degree.
Well, and I think the demand will make sure that happens, right? If therapists are having to turn people away, at some point they're going to say, okay, I need to learn more about how to handle this.
Well, unfortunately, what we see in too often in clinic, and we hear this story, and you folks have experienced it themselves, is that they don't turn people away. They tell them that they know how to treat OCD, and then they proceed to treat it incorrectly, right? So that's unfortunately what happens is, within medicine, people don't practice outside their specialty, they refer, right? If somebody who has bad, liver disease, I'm not going to try to treat the liver disease myself as a psychiatrist. I'm going to refer them to an internal medicine doc who knows how to treat liver disease. And yet what we see often in the therapy world is that simply doesn't happen. Clinicians will post on their Psychology Today page every possible psychiatric disorder there is, claiming that they know how to treat all of them. And then when the people come in, even if they are making an appropriate diagnosis or the person already has a diagnosis and they're being referred to that therapist, oftentimes the therapist just simply does not either refer them to someone else who knows how to do ERP, nor provide it themselves if they're treating it. So, as Becky mentioned, roughly half, a little bit more than half of the 72,000 people identified in our study who had OCD or firmly diagnosed received a mental health assessment within the network at all. Maybe some of the other ones received mental health assessments outside the networks, in private offices. We don't know that because we don't have data from there. But even of those who got the mental health assessment within the network, still about 2/3 of them didn't end up getting exposure and response prevention or ERP.
That is crazy making. We need more screening. We need more training around that screening, and then what to do if the person does, in fact, screen for OCD. How do we, as lay people, go about helping in that effort? Someone's listening right now and they're really frustrated. Is this about talking to insurance companies about how they cover? Is this talking to the healthcare system about screenings? Is this talking to medical academic institutions? Where can we make an impact that maybe 10 years from now, these numbers aren't so dire?
Yeah, it's a great question, Liam. I think even pulling it back further than that, like there are definitely issues with insurance, with healthcare systems, but it's actually above that. I think there are already professional standards in place that govern, like, for any kind of illness or any kind of specialty, that like explain in a lot of detail, if this illness presents, this is how it should be treated, right? And it takes you through a journey if you specialize in that area. That's just simply not happening for OCD. So the types of changes that could happen is, I'll come back to your original question. So what you and Alicia are doing is extremely valuable. So, like, first and foremost, I still think that raising awareness and correct awareness about OCD and broadening the number of people who are hearing these stories and understanding the real suffering and seriousness of OCD is incredibly important. To your earlier point, Liam, I think it does get brushed off, generally speaking, as a personality trait, wanting to be really neat. And even me myself, I don't have a background in OCD. I've been with the foundation for about 2 years. I've learned a lot about OCD. I did not understand how serious and debilitating it could be when I first started.
Mm-hmm.
When people start to understand that, it changes their entire approach and thinking about this disorder. And then that, now coupled with the fact that so few people are getting access to treatment, it is in fact a crisis. So raising awareness, sharing lived experience stories is incredibly important, number one. Number two is talking to people who are in decision-making positions of power. It's not just government. It can be your primary care office, right, or physician's office, right, and telling them, like, hey, are you aware of this? And there's a free screening tool on this foundation's website that's evidence-based. The screening tools exist. We work really hard at the foundation to disseminate them as broadly as we can, but we need help to do that. That's helpful. Talking to governmental leaders about that this is a serious issue, without more targeted, specific policies that either, to put it bluntly, force screenings to happen. There needs to be more funding available to help promote it and make it available for free, because I think that's one of the only ways we're going to get people to do it. I have one of my very closest friends from college is a primary care physician. She's brilliant. She's caring. She is required to screen and cover so many things already in a visit with a patient that adding on one more thing and expecting that people to do it, it's not going to happen. And it's not that health systems and hospitals and doctors' offices don't want to, right, what I was saying before. It's just, unfortunately, if it's not forced, it's probably not going to happen. And I think the other thing is that what I was saying earlier is around advocacy. Our job is to represent the OCD community. We do it every day. I think that the team that works there, we're a small nonprofit. based in the US, based in Boston, Massachusetts, but we're an international organization, work really hard to raise awareness and advocate for issues like this and others. But it's a steep hill to climb. And I think, again, it's just adding more voices to share the white paper with someone you know, share it with 10 people that you know. I think that starts to help catch fire and raise awareness about this in a way that hasn't really been happening so far. I mean, all the evidence is out there. It's a common disorder. Treatment exists. Like Sanj said earlier, just wouldn't be tolerated for another illness that was this common, that there's evidence-based known research after decades and decades of research support that ERP is the way to go, and it's not used.
Quick break. We'll be right back. But first, a word from our sponsor.
The same distressing, unwanted thoughts keep playing over and over in your mind. The same rituals keep eating up your time, holding you back from enjoying your life. You've tried talk therapy before and spent session after session diving into those thoughts, trying to understand them, trying to fix them, but somehow they just get worse. And the shame piles on because you think, why isn't this working? What's wrong with me? If this sounds familiar, here's what you need to know. You are not the problem. You're experiencing something that a lot of people with OCD experience. Getting your life back is possible because OCD is highly treatable. It just requires a completely different approach than other mental health conditions. In fact, standard talk therapy often makes OCD worse because it encourages you to analyze those intrusive thoughts or try to replace them with positive ones. But with OCD, the more attention you give the thoughts, the stickier they become. That's where NoCD comes in. NoCD provides virtual therapy designed specifically for OCD. Every single one of their therapists is extensively trained in a type of therapy called ERP, or exposure and response prevention, which is the most effective treatment available for OCD. And they get their training from world-renowned OCD experts, so they truly understand what you're dealing with, even the stuff that feels impossible to say out loud. In live, face-to-face virtual sessions, your NoCD therapist will teach you how to take the power away from intrusive thoughts so you can live the life you want to live. In between sessions, you'll be able to message your therapist anytime, join dozens of live support groups, and continue your progress with other expert-developed therapy tools. NoCD is also covered by insurance for over 138 million Americans, and their team makes it really simple to get started. Visit nocd.com and book a free 15-minute call. That's nocd.com to learn more and talk to someone who can help, because you deserve treatment that actually works for OCD. And now, back to our show.
Within the white paper, if people get a chance to take a look at it and read it, we break down the recommendations for different people. So we've got particular recommendations for healthcare systems. We have recommendations for insurance companies. We have recommendations for clinicians in their own practice. And then we have we have recommendations for everyone, for lay people, for folks with OCD, for family members, and so on. And they include advocating, raising awareness, if they have connections with training programs, if they have connections with policymakers at a legislative level, if they have connections with licensing boards, if they have connections with leaders of healthcare systems who institute practices like screening, if they're contacting their representatives to exert some public pressure on making changes in these health, primary care, and mental health systems. I think there's a bunch of different what we call scalable solutions that you can support. And we list out, including the ones that Becky just mentioned, where I think mobilizing public pressure can have a major impact.
Becky, if you could wave a wand and, make 3 changes to improve OCD diagnosis and care in the U.S., what would those 3 things be?
It's a great question, Liam. I think I will come back to the awareness piece. I think that if I could wave a wand and everyone in the world had a accurate understanding of how serious and debilitating OCD is, that would immediately change so many things. And the level of compassion and passion to change the problem that we're in, I think would really rise to the top. I think that would be one thing. I think the second thing I would do is that, we have such a strong community of people with lived experience or with parents or others who are somehow affected by OCD and related disorders, which we haven't talked about yet, that you're not people aren't alone, and to understand that, you are seen, this disorder is understood by a pretty big community of people. We're just missing that connection to get more people connected in. And I think that is the other piece, is that, especially with conversations that are more heavy and data driven, there really is hope, and there are understanding that people can get treatment and they can dramatically improve. They can feel full relief at times from their symptoms, and that is a very possible thing. I think the third thing, I'd be remiss if I didn't mention, the IOCDF's almost entirely donor-funded nonprofit. It would be sort of like unlimited funds and resources to really dig in and just dramatically broaden our reach. Many of the things we're doing are activities that will help address these problems, but we're limited by how quickly and how broadly we can do them by the resources that we have.
Dr. Saxena, someone's listening and they've got an inclination that someone in their family has OCD. I know we can go and look at the screening on IOCDF.org, and people should do that. But just for the purposes of this conversation, what are some things they should be asking to determine whether or not they or someone else they love does, in fact, have OCD?
I think everyone who has an inclination that they might have OCD, or one of their family members or kids might have OCD, should really seek out a professional evaluation, because it can be tricky sometimes, and we're not expecting everyone to be self-diagnosing and to have expertise in being able to sort out which disorder their symptoms go with. Certainly, screening tests and screening questions like those found in those brief screeners that we have, that are 4 or 5 questions each, can go a long way. But a lot of folks have already done that. The next step is to go seek help. Sometimes there's a good deal of reluctance to seek help, or people will say, "Oh, I just want to get over this on my own." Right. But nobody would say, "Yeah, I'm having seizures. I have epilepsy. I just want to get over it by myself." Right. And yet I hear that from folks with OCD all the time, not wanting to engage in treatment because somehow they think that they can just do it on their own without any treatment.
What are some of the questions on that screener, just for our knowledge?
The general questions are things like, do you have repetitive, intrusive thoughts or fears that keep coming to your mind that cause trouble that you didn't know, that you can't control? Number
Check.
2, do you have repetitive behaviors like checking, washing, cleaning, having to do things in particular rituals or particular orders, or even mental compulsions? So I think the screeners ask about kind of the most common ones, about repetitive behaviors, intrusive thoughts, and then some more specific questions about the most common symptoms in the kind of the major domains of OCD, and that have a very good sensitivity and specificity for identifying the disorder.
Something I always say, especially to parents, and I encounter people all the time, I like to tell them that I've met so many young adults who got diagnosed in treatment and they are thriving.
Yeah.
And it's just, again, like, I just think I would encourage people, everything Sanj said, totally agree with. And then also just like, there is a community and there are supports for parents or for people with OCD to just learn more about what the outcomes can be like. There are so many stories of success and people thriving, and they are more than willing to share. Even on our board of directors, people spend hours every month talking to parents who are here in their journey with their kid. They've lived through it. They've lived through it for 20 years, and they can tell them, like, there is light at the end of the tunnel, and it is possible to get better. We have an annual OCD conference that we host every year in different cities in the US. It's an amazing way to engage and connect with people. There's the leading experts in the country and even in the world about OCD and how it works, how the treatments work, and just general supports. So I would just add that to, like, really encourage people to at least seek out understanding that there is a community of people with OCD or affected by OCD that exists and that are there for them.
I love that message. And
Yeah.
Alicia and I are both going to be at the conference, by the way. Shout out.
So excited. Yeah, we'll be in Seattle in July, right after the 4th of July. So folks want to check that out also on our website, IOCDF.org. We'd love to see thousands of people join us in Seattle.
And Dr. Saxena, I think you're actually the first psychiatrist to be on our show. We've had a bunch of psychologists and people with lived experience. So I just want to ask you, because we get this question a lot, Is there a medication for OCD?
Yeah, there are several medications for OCD. So the category of medications that's been found to be effective for many people with OCD are serotonin reuptake inhibitors, or SRI medications, and they include these was the most commonly prescribed psychotropic medications there are. Right? The common sorts of medications that are used for depression, they're used for several anxiety disorders, and they're used for OCD, and they can be very effective for OCD. But the dose that's required and the duration of treatment that's required is quite a bit higher. So typical ones would be fluoxetine or Prozac, sertraline or Zoloft, fluvoxamine or Luvox, escitalopram or Lexapro, citalopram or Celexa, and then one from a different class that's called clomipramine or enafranil. Those 6 or 7 medications either are FDA approved in the United States or abroad, but they've all shown, efficacy in decades of rigorously controlled double-blind trials for OCD. And for each given trial of one of those medications at the appropriate dose for the appropriate duration, roughly around half to 60% of people will respond. So if they don't respond to the first one, okay, then they can try number 2 and number 3 and so on. When people only get a partial response, kind of an insufficient response to one of those primary medications for OCD, then there's several groups of medications that can be used as secondary ones, like what we call adjunctive treatments, to augment or boost the response. And so we frequently will use combinations of medications, one of the primaries at full dose plus a low dose of one of the boosters or 2 of the boosters. So with proper medication treatment, we can get that percentage of people who have a significant improvement just with medications up to, maybe up to 3/4 of folks. Nevertheless, medications almost never completely resolve OCD symptoms by themselves. Almost always, people are going to need exposure and response prevention, or more broadly CBT, in addition to the medication to really get the greatest degree of improvement. And that's especially true if they have more, moderate to severe OCD or complicated OCD that includes other coexisting conditions. Essentially, the more complex the problem is, the more likely someone is going to need a more comprehensive treatment approach that combines medications and ERP.
I'm comfortable sharing that I'm on escitalopram and buspirone, actually, as the secondary one.
Mm-hmm.
And the most common question or concern, and this came up for me and for other people who are considering this with OCD, is 1, am I going to be on it forever? And 2, they worry about the side effects. I know that was a concern for me. So can you just address that quickly? Side effects and are you going to be on this for the rest of your life?
Sure. Those questions are, I agree, 2 of the most common that I'm asked when I start talking with patients about the potential for medication treatment. So the first question about, do I have to be on this forever? It really depends. It depends on how well they respond, and it depends on whether they receive ERP. The only kind of treatment that can substitute for a medication when it's working and someone wants to potentially get off of it or taper off at some point in the future is if they get ERP. And ERP can certainly reduce the relapse rate a lot as compared to so if somebody's getting a good response to medication and then they just taper off of it, 2/3 to 3/4 will relapse within a year or 2, right? However, if they get ERP, that relapse rate drops down to maybe only about 1/4. So it's not 0, it's still 1/4, of people still will relapse. So there are some folks, some percentage of folks who may need to continue on medication long term, just as they would for, hypothyroidism or diabetes. And again, I use that analogy of somebody coming in with epilepsy saying, how long do I have to be on this medication? The answer is there, whenever you want to start seizing again, go ahead and stop. Right? I mean, so
Yeah.
I think the more that people understand that medication treatment of OCD or ERP for that matter is not really any different than the type of treatment and the way of thinking about treatment that's for any potentially chronic long-term disorder.
When is a child too young or not too young? I'm concerned, you have a child, his brain is still developing. What would your advice or expertise be on giving medication to a child?
Sure. So for children, definitely ERP is the first line of treatment. For adults, it could be either one, either starting with medication or starting with ERP, depending on the severity. For kids, definitely CBT using the technique of ERP is the first and primary recommendation in all the practice guidelines. However, that doesn't always work, and it's not always sufficient. And the kid may have other disorders also that need medication treatment. They might have other severe anxiety disorders. They might have comorbid ADHD. They might have coexisting severe depression or bipolar disorder. So the answer of what is too young really depends on what the need is. It's always a balance between the potential benefits and the potential risks. And you're right that there are always concerns, but these medications, several of them have been well studied and are FDA approved down to even age 6. And there are some kids who are, in their elementary school years who have OCD that is so severe or complicated that they need medications, either on their own or in addition to the ERP. And these medications do work, and they have been tested. And this is where child and adolescent psychiatrists are really the experts in dealing with kids. But so the general rule is, as much as possible, you try to maximize the therapy first before you move to medication. However, if it's necessary and the kid is really suffering, then you have to use medication. I see a lot of parents who are desperately wanting to avoid having their kids on appropriate medication, and they're taking them to, hypnotherapists or to naturopaths and trying herbal remedies, thinking that those are safer, even though they're not tested and they're not FDA approved. And the kid is just going on suffering year after year after year after year and not getting better. And it's really a product of lack of accurate understanding, as Becky pointed out, that leads to stigma and fear that they wouldn't have, if their kid had a heart disease or liver disease or a neurological disease. Often it's the same brain, often very similar circuits, but somehow people put psychiatric disorders in some separate category when that really doesn't make any sense at all.
Becky, on the report itself, I just wanted to ask a final question about it, which is that we've been through some of the dire results of this study and what needs to be fixed and some of the solutions. Were there any moments of hope as you were going through that study where you said, okay, this is a sign that we can make this better?
So I'm an eternal optimist, right? So I'm always finding the positives in everything, probably in an annoying way. Sanj can speak to that. But I think, or not. Yeah, I mean, I think the things that give me hope are, while they're complicated and multi-factor problems, they're solvable. I think the other thing is that the IOCDF exists. Right. This is the work we do. We have our long-term vision is that anyone affected by OCD or related disorders has immediate access to treatment. I know one day we'll get there. We're not going to get there in 3 years. We may not get there in 10 years, but I know that we can get there. The other thing that gives me hope with this is that the recommendations that we laid out, those aren't shocking. There weren't shocking revelations. That the numbers are disheartening, no question. And I think it's always hard when there's a problem and there's been.
Oh, sorry, Becky.
Okay.
She's very upset about the state of.
Did not like my answer. Yeah, he's like, you are annoying.
He does look very upset about the OCD.
The white paper. I saw her reading it in the background a little bit.
Yeah. So, the other thing that gives me hope is that the recommendations that we've laid out many of those things are we're working on already. Training, we're training over 1,000 clinicians a year, raising awareness, awarding research grants and advocating for more funding for research. Like, these are all things that are going to help address the problem over time. But like I said, it can be slow because it's limited in what we can do in terms of resources as a small nonprofit. But I think we have a very good roadmap of what needs to change and what needs to happen. And you better believe that we're already pounding the pavement and working towards that change. And in the new year, we'll be doing that as well.
I would echo that. I think the biggest reason for optimism and hope is that the treatments do work. For the vast majority of people with OCD, medication, ERP, some combination thereof really do work. And especially if the ERP is delivered in the format that's necessary for that level of illness, depending on what it is. So if once a week outpatient treatment isn't sufficient, you bump up to intensive treatment. And for many people with OCD, intensive treatment really is the best form of treatment. It's usually temporary, and then you go back to outpatient again. And so the same reasons for hope are the same reasons that it's frustrating, because I agree with Becky. All of these are eminently solvable problems, right? They require changes in training. They require changes in screening. They require improvements in awareness. And all of those are eminently doable. It's more finding the will, getting to the people who make those decisions, convincing them of the need for it. And the public health need is really, really striking. But the hope is that, yeah, it could be done. These are not insolvable problems.
How can people find the white paper online if they wanted to look up these studies themselves?
Sure. It's available on our website at iocdf.org/OCD care crisis.
Dr. Sanjaya Saxena and Executive Director Becky Deusser of the IOCDF, thank you both so much for the work that you're doing and for sharing it here on our show. We really appreciate it.
Thank you so much.
And thanks to you, Alicia and Liam, for everything you're doing. The podcast is phenomenal. It's so brave that you're so raw and out there and sharing your story. It is helping so many people, and I have no doubt it's going to grow and help even more people. So thank you.
Thank you so much.
Yeah.
I feel like my OCD is loud. It's a shitty week for me. It's just kind of like all the things. The holidays are weird for me, and they're very triggering for a lot of reasons. I was raised Jewish. My mom was not. She tried to convert. I went to a Hebrew school, and I always wanted to celebrate Christmas, but it was obviously not allowed in my house. But it wasn't like I just not allowed. It was like my mom brought home a little Charlie Brown tree because I really wanted one. And we weren't reading out of it. You know, it wasn't like I was studying Christianity or anything about Christmas or anything having to do with the religion. I just liked the tree and the lights. And so she brought one home, and my dad flipped out. It was such an overreaction to it that I always get very conflicted this time of year, because it was instilled in me that it was wrong to celebrate Christmas. And obviously my husband grew up celebrating it, and I want that for my children. I don't know how to do it for them. So I do my best to like get the tree and decorate it. I wasn't raised with that. I have no idea what I'm doing. I truly, but we didn't really lean into Judaism either. And so we did for like 4 years, and then my grandfather passed away. So to answer your question, it's just a weird time for me, and I really want it to be special, and I try to create all these traditions for them. I didn't grow up with traditions in my home. And so I don't know. I don't know.
You get into a funk?
Yeah, I do. Less now. My kids are getting older, but when I first became a mom, it was really tough because I was like, I don't have a clue what to do. And am I doing this right? And is it enough? And am I teaching them what it's about, the more important things? It's not the gifts, and so a lot of insecurity around this time of year. It's gotten better, and then it's like the family being broken up, and, my dad lives on his own somewhere. He has 5 children he doesn't talk to. And my mom is in a wheelchair. She's quadriplegic. I feel bad that I can't be there for her. It's a lot. It brings up a lot of emotion.
One, that's a lot. That's a lot of stuff going on. There's a lot of trauma in your past. And I think, too, even for people who haven't been through that, what happens during this time of year is there's a lot of comparing that goes on. So someone who came from a background like yours that was really difficult, you see everyone else in their traditions and the way they experience this time of year, and it makes your experience feel even worse by comparison. And then someone with OCD, on top of that, being able, which, having OCD can make it so difficult to experience those things anyway and be in the moment. So when you see everyone else seemingly in the spirit and enjoying all of this and the hot chocolate and the lights, and you feel like you can't, it adds the shame of like, oh, and I'm this loser that can't feel any of this.
Yeah, and then I take it even further, and I'm wondering, is anyone truly enjoying it, or is everyone just stressed out trying to one up the other person, and it's the Joneses keeping up with the Joneses, and it's all how much of it is in fact real, you know? And I think there are moments of it that are amazing, and I love being with my family and playing board games and being home and cozy and drinking my hot coffee and seeing the lights on the tree. I love all of that, and I love the meaning behind it, if you choose to believe that. But I also just question a lot of, and I think that, like you said, that is the OCD, is just what's real, what's true, what do we trust, you know? So
Yeah,
it adds a lot of layers to my situation for sure.
and I think America in particular has this problem with being in the moment. So people turn from Halloween, November 1st, people start putting up the lights, getting their tree, going nuts into Christmas. And it's almost this rush to experience the thing or enjoy the thing and make sure you're in the season instead of take your time.
Yeah.
Thanksgiving falls in between those. That, don't give Thanksgiving short shrift. Like, take things as they come and try to stay in the present with it. And then again, you add in OCD and you're like, well, there's no chance. Like, the number of times during the Christmas season, I'm like, I didn't listen to enough Christmas music yet. And I didn't do this.
Did you bake enough cookies with your children? Did you do the gingerbread houses? Did you go look at the lights at the local place? Did you take them ice skating? Did you, it's like we lose focus on what's truly important, and consumerism is at an all-time high, and everyone's trying to get the next best thing. And Target's move has changed the shelves months in advance, right? It's like, it's just, everyone needs to slow down. So I just try to remind myself that. And you can't buy love. You cannot buy love. So if you just love those children in your house, and even if you can't give them all the things, and even if you can't even give them the experiences that you wish you could, you can love them. You can love them a whole lot. And that's what I do.